Okay, I think I'm going to go ahead and start back up again. Just about, maybe I'll give it another 30 seconds. I think my clock is a little fast. Well, it's wonderful having everybody here today, part of our fall symposium, work as a social determinant of health, such an important topic, and now more than ever. So it's my pleasure to introduce Dr. Jennifer Dimmoff. And Dr. Dimmoff is actually an affiliate faculty member of our institute. And she is also an assistant professor in organizational behavior at the Human Resource Management and in organizational behavior and human resource management at the Telfer School of Business, University of Ottawa. Prior to joining the faculty at Telfer, she was a faculty member at Portland State University, where she spent 3 years, and she remains also as an affiliate faculty member there. Dr. Dimmoff's primary area of research focuses on the intersections between leadership, occupational health and safety, and employee training and development. And she has worked with local, national, and international organizations to develop, deliver, and evaluate evidence-based solutions to real workplace problems. So, Jen, it's my pleasure to turn it over to you, and thank you so much for being part of our fall symposium.
Thank you very much, Leslie. Thank you, Phoebe and Dan, and everybody who organized this event and it's possible, even under these circumstances, which is a phrase we're all using far too often. As Dr. Hammer mentioned, my name is Dr. Jennifer Dimmoff, and I am an assistant professor at the Telfer School of Management at the University of Ottawa, which is in Canada. But I have very close ties to Portland and to Oregon and to the United States. So today, I'm really excited to share some research that I've been conducting with a team since March related to COVID-19 and the impact that organizations and leaders have had on employees, as well as some certain socio-demographic variables related to where people are living and working and the impact that that has on psychosocial outcomes as well as physical health. So I'll just make sure I can get this advancing properly. Okay, so to start us off, largely the purpose of this body of work that's been going on for the better part of 7 months, which, by the way, we had not planned on doing this research for the better part of 7 months. I don't think any of us had planned on the pandemic, well, lasting as long as it has. So you'll have to bear with me in terms of the reality that some of this data was being collected in real time, which is quite powerful, but also means that there were decisions that we made along the way that perhaps are not so relevant today as they were back in March and April. So anyway, the larger kind of overarching purpose of this body of work has been to study the impact of organizational responses in terms of communication, policies, safety practices, leadership behaviors on employees' health, well-being, and work outcomes, both in the short term, and now we've been able to adapt our studies to also capture the long term. And this research was funded by 3 different funding agencies in Canada that all had some kind of COVID-19 rapidly release funding opportunities to study phenomenon like we're living right now. So given this kind of mixed audience of both academics and practitioners, I always like to have some kind of a so what factor associated with this research. So more along the lines of, why should people in industry care, and what can they do with this information? And so the so what factor in this case is that there are very few existing actionable best practices related to successful organizational responses to these types of external crises that affect entire labor forces. So we wanted to help collect process-oriented data, so meaning data collected over time to better understand what information is needed to inform those best practices. So as Leslie mentioned at the beginning of this, a lot of my research does focus on interventions and training and development. And so for those of you who have, heard me speak at this event in past years, that's what I've mostly talked about is interventions. And today is a little bit different in terms of we're collecting information that will ideally inform interventions, policies, training programs, and practices down the road. So this is kind of that information gathering phase. And as I said, this research did not start off as big as it has become because we did not anticipate things lasting as long as they have. And so to accomplish this kind of that overarching goal and collect the information really needed to inform best practice, we undertook a series of 7 different studies, and it's actually expanded in the last few weeks to 8 and now 9 different studies, all with different samples, some similar sampling strategies. So we have longitudinal designs collected with data collected over time, as well designs, so more data collection on a day-to-day basis, as well as qualitative data collected with the kind of this goal of being able to have as much of a comprehensive answer as possible that can apply to as many different environments as possible. So people who have continued to work at work versus people who are now working from home versus those in a hybrid type of situation, as well as even those who have become unemployed or furloughed as a result of COVID-19. So today I'm only going to be discussing findings related to our first 3 studies because even though we're still collecting data on these 3 topic areas of organizational response, the experiences of frontline retail workers, as well as the relationship between organizational response and post-traumatic stress disorder, we're still collecting data on these areas. So this is positioned as preliminary data sharing that I'm doing today. But there are our most complete data sets. So they provide us with a somewhat clearer picture of what's been happening over the last few months. So just that's the caveat there. And of course, given the amount of data collected and the funding, this is not something that I have accomplished at all by myself. This has been led by Dr. Kevin Kellaway at St. Mary's University, who is the primary investigator on our largest grant. So along with him and Dr. Stephanie Gilbert and Dr. Jane Mullen, both researchers in Atlantic Canada, as well as a wonderful team of research assistants. None of this would have been possible because we had really planned on spending the amount of time and energy on this as when we first started out back in March, when this looked like it might be something that would last for a couple of weeks, maybe a couple of months. So our background here, looking at all of this, this kind of overarching framework, is that crises and disasters are not new to organizations. Many organizations have crisis mitigation plans, policies, and procedures in place to deal with crises of both small and large scale. Rarely, however, do organizations plan for this scale of external threat that affects really the entire labor market and the global economy. So this pandemic has really, well, as we all know, been a unique experience. And we hope that it's unique and we don't have to live through many more of these experiences or any of these experiences in the future. But in these types of situations, organizations or people's employers can really become the vehicle for public health information and enforcement. And rather than just listening to public health officials, people start to look to their leaders and their organizations and to their employers in terms of the decisions that they're making and the information that they're providing. So building upon past research on virus outbreaks, we have this fairly linear model by which employees' perceptions of their organization's responses to a major crisis, such as disease, and in this case it was the Norwalk virus, influence whether or not and the extent to which employees feel afraid of being infected. So basically, the extent to which they perceive the virus as a threat, coupled with the extent to which they feel like they might be protected in their workplaces. And that leads to these more behavioral and psychological outcomes of feeling protected, feeling safe, whether or not you experience stress, experiencing declines in health, getting sick, as well as engaging in safety practices such as hand washing or now in the mask wearing. And coupled with this kind of background, our recognition that generally there are different types of stressors or stressor categories that people respond to differently, both psychologically and behaviorally. And one of the really unique features of this pandemic has related to the types of stressors that have emerged over the last 7 months or so. And prior research, and this is not totally comprehensive by any means, but prior research suggests that there may be these kind of 4 overarching categories of stressors or types of stressors that differ in terms of how specific their time set or time of onset is, as well as their intensity. So whether it's experienced as a kind of a slow burn or a very acute experience, as well as how long they last. So it's not just the time of onset, but it's also the extent, the duration of the experience. So this pandemic has kind of brought this tidal wave of stressors where not only are people experiencing all 4 of these types of stressors simultaneously, but it's also been very difficult to distinguish between what is a catastrophic stressor and what is a traumatic stressor, or what is a chronic stressor versus a daily hassle, where daily hassles certainly can turn into chronic stressors under normal circumstances. But now you couple it with these major life events and major world events, more common with traumatic and catastrophic stressors, and we kind of have this perfect storm. So as part of that, we end up in this situation where it becomes, when we can't basically distinguish stressor classification to say, this is a chronic stressor or this is a daily hassle. What happens is we lose our ability to, as researchers and just as people, to mitigate those challenges, because we tend to have toolkits to say, okay, so in the event of excessive daily hassles, this is how we should respond. Or employers looking at this in terms of, okay, so we have a workforce that is experiencing chronic stressors. Here is our toolkit in terms of mitigating those chronic stressors to reduce the potential for chronic strain and other more serious mental health problems that can last and be exacerbated over time. Now we have this situation where we have a coupling of traumatic stressors, chronic stressors, daily hassles, catastrophic stressors, and our toolkits don't work as effectively because we don't necessarily know how to classify what we're dealing with at any given moment in time. And the fluidity of this situation has brought with it a lot of uncertainty. So we have this general model, and as I said, this was something that we actually designed in February, and thinking that this was going to be something that would last for a short period of time. But this is what has conceptually grounded all 7 of our studies, even though it was something that may feel a bit outdated, but basically posits that there are a combination of individual factors and organizational factors that lead to more specific time-sensitive or short-term psychological outcomes, such as fear or feelings of anxiety. that will result in outcomes that are more longer term in terms of psychological well-being, self-protection behavior, so safety behavior, so hand washing, personal hygiene, things like that, as well as more social behavioral responses, such as stigmatizing attitudes towards people who do wear masks or don't wear masks or who become infected. So there's a lot of judgment going on in terms of the both psychological and behavioral responses associated with the pandemic. So one thing to keep in mind with all of this is that all of the research that I'm going to be presenting today gets at some aspect of this, but perhaps not totally comprehensively yet. So one of the questions that we had not necessarily originally started with, but transformed over the course of May, June, July, is whether or not the pandemic is a traumatic stressor. So originally we were really conceptualizing it, along with most researchers, as either a catastrophic stressor and something at a very high intensity and very specific onset, or as something that would pose an inconvenience, so more similar to daily hassles. But as time went on, this became the real question that we started asking of, is the pandemic a traumatic stressor? And if so, for who? So kind of what individual or organizational level factors are creating a moderated effect of whether or not people are experiencing that transition from fear to more serious mental health issues. So in our first earliest study, we surveyed people living in Canada and in the United States, mostly out of the sake of convenience and localizing this to those two countries. So our sample was pretty evenly split between men and women. The mean age was around 50, so a little bit older for considering the working population. The majority were full-time workers and had an average tenure of about 12 years in their organization or in a similar role to what they were holding at the time of the survey. So that's just kind of what the people look like in terms of very, overarching categories. And it's interesting because while we had initially thought chronic stress might be something that would be apparent in this sample, and this is time one, so we're looking at April of 2020, we found that health problems and financial strain, so two markers of chronic stress, were relatively low in both countries. So that kind of tells us that at least using those two particular variables, so we're not looking at everything, just those two, but there are relatively low levels of strain among our sample. And so for those of you in academia, or for those of you who are doing these types of evaluations, we were using the GHQ to measure health, which captures both physiological and psychological symptoms of health and well-being. And over time, financial strain declined in both countries this was over the summer, from April to June, but more substantially in Canada. So we'll see a few of these trends related to differences in Canada and the United States. And I have a few thoughts on that, but would certainly love to hear your thoughts on that as well. So anyway, these numbers are similar to what you would see in non-pandemic times in terms of health and financial strain in the population. So we started looking to the more traumatic stressors in terms of the data that we had been able to collect. And because we didn't really have compelling evidence with our specific variables of a phenomenon of chronic stress early on in the pandemic. So we looked at post-traumatic stress disorder, and this was something that came out of some focus groups that we did with a group of employees, and they kept using the word trauma. as well as the words, grief and trauma kept coming up and coming up. So we were able to capture this in the data. And in a typical general population sample, you'd see 2 to 4% of people scoring at clinically high enough levels to be diagnosed with PTSD. And then in first responders, non-military or military, seeing 8 to 32% prevalence rates among first responders. With our sample, which is general population workers, we specifically did not target healthcare workers in this particular sample, or active duty military. We find very high prevalence rates for PTSD, with Canada being about 10% higher than in the United States. So these PTSD scores are extraordinarily comparable to what you'd see on the high end among frontline responders. And we have this difference between the US and Canada, where in Canada, it's a 29% rate or prevalence rate compared to 20% in the United States. And we've done multiple iterations of this data collection with different samples, and we consistently see these findings of the difference between Canada and the United States, and these very high levels ranging between 20 and the high 35, 36%. So PTSD prevalence is high. And what we kind of looking at this was trying to understand, okay, so this is PTSD is one part of this puzzle. Do we need to be looking at it as an outcome or as a mediating factor or even as a predictor of other outcomes down the road? And what we, for the most part, are looking at here, or were looking at, was change over time. So collecting data in April, and then again in June and July, and then again now we're collecting, or I guess October, and we haven't gotten to the analysis on that data collection yet. But we find that there tends to be these kind of categories of correlations, or of variables that correlate with post-traumatic stress disorder. Leadership, most strongly passive leadership, so negative types of leadership. Supervisor support at the organizational level and at the immediate supervisor level, as well as individual predictors of whether someone will experience high enough symptoms of PTSD to be potentially diagnosed with PTSD. And those ones are financial strain and general health. So basically, what was your health initially in the early phases of the pandemic, and how does that translate into post-traumatic stress disorder over time? So while the evidence for chronic stress was relatively low at both time 1 and time 2, there may be predictions of PTSD at time 3, or basically as we're getting into the latter of summer and early fall. So I'm going to present a couple of mediation models here. I don't have very many statistics listed in here, but these have been tested with path analysis. And so basically what we see is when combining these variables at different time points, we can observe some predicted relationships that align with our hypothesized model of organizational or individual factors predicting psychological experiences, predicting health outcomes. And in this particular situation, we have laissez-faire leadership, which is another way of phrasing passive leadership, positively predicting whether someone experiences a fear of infection, which positively predicts post-traumatic stress disorder likelihood. So basically, this means that if your leader doesn't really care about you, or doesn't really show that they're interested in much of anything related to you, the work, keeping you safe, COVID, any of that, they're not present, and you're more likely to experience fear of getting COVID at your workplace. And so we had different types of fear measures. We had a regular fear measure of just fear of COVID in general versus fear of infection at your workplace. And when we model this with general fear, the relationships don't hold. But when we specifically make it to the workplace, we see this relationship where people are afraid of becoming infected with COVID-19 or with coronavirus at work when their leaders are passively engaged with them. And what that translates to is over the course of months, post-traumatic stress are scoring highly enough on PTSD scales to have it be clinical levels. So very significant impact of leadership behaviors on employee mental health well-being. So in study 2, contextualized, we used a lot of the same types of measures, but really honing in on frontline workers and retail workers who don't have the option to work from home. So these are all retail workers working in the field, interfacing with the public. And again, what we see is this trend of some kind of organizational factor predicting fear of infection, predicting PTSD at time 3. And in this particular case, the major predictor that evolved from this data set was civility. So whether you experienced incivility in your workplace at the hands of coworkers or the general public impacted your likelihood of being afraid of getting infected at work and whether you would experience PTSD over time. So again, these results kind of demonstrate the potential huge impact for workplace factors on rather significant health outcomes in a very short period of time. And moving it kind of forward to looking at PTSD as a predictor of other outcomes. So this is looking at PTSD collected at time 2, so midsummer, to presenteeism collected very recently. And this is preliminary data that has not been totally and fully cleaned, but I wanted to give you a bit of insight into some of the modeling that's happening here. Is that not only, so people are scoring high on PTSD, were more likely to engage in presenteeism in the workplace, but even more so when their leaders were passively engaged. So again, compounding this, and when we're talking about presenteeism, we're not necessarily talking about people who are physically in the workplace but disengaged, but basically they're preoccupied with thoughts about their health or their negative health or COVID to be able to do their jobs effectively. And so looking at this from a continuing that so what factor approach, it's interesting, but not really at all surprising, that a variety of individual factors, in addition to organizational factors, and when combined with organizational factors, predict fear. So people who have a higher potential for risk of exposure tended to experience more fear. People who are immune compromised tended to experience more fear. As the pandemic went on, age was also a predicting factor, where older workers, as we learned more about coronavirus and the impact that it has, or the disparate impact that it has on people of different ages, well, workers over the age of 50 started reporting more fear as time went on, as well as financial strain, predicting fear. And then the positive thing with this is that organizational factors help to attenuate some of these more negative relationships. So people who had stronger leaders, or not stronger, it's a poor way of putting it, leaders who were very safety conscious, leaders who showed high levels of social support, leaders who were engaged with their employees in the months following the pandemic, that helped to attenuate these experiences of fear. Same thing with people working in workplaces where there was exposure reduction practices, sick leave policies, basically designed to protect workers from infection, as well as improved communication about the nature of what the organization was doing, how they were preparing, how they were communicating about the coronavirus and the impact that it was having on the workplace. But all of those helped to attenuate these individual factors associated with fear, and together have led to important behavioral outcomes related to social distancing and self-protection and other protection behaviors such as hand washing and mask wearing. So continuing in this vein, we did another study. Now this is only with Canadian workers, where we were trying to really hone in specifically on PTSD and the predictors of PTSD. So we specifically used a very robust screening tool, basically designed rather than to screen people out of a sample, which we often do when we're working with workplace samples, is to either control for it statistically or to screen participants out who score too highly on a particular psychological measure. In this case, we were actively recognizing it with the screening tool. And what we find is that of the people experiencing high levels of post-traumatic stress disorder, or at least high enough to meet the cutoff, most of them are working at work or in a combination of work and work from home. So there is a differential impact for those working on the front lines, or those having to interface with the public, or those having to go into a workplace versus those working from home. So it just gives us a little insight into who this might be impacting more significantly when compared to another group of employees. And with the minimum, looking at the kind of the minimum PTSD cutoffs, you see that even months into the pandemic, so this is the data collected in July and August, prevalence rates continue to be high. So with between 26 and 36% of employees surveyed reporting high enough levels of PTSD to be considered at the clinical levels. We've taken kind of a sneak peek into our most recent data collection, and we see numbers very much in alignment with these trends. So we're not seeing it increase, which is good, but we're also not really seeing a decrease. So we'll have to look into the kind of the statistical modeling of that, of whether any decreases we're observing are significant or not. I don't know. And what you're seeing here is kind of this depiction of Canada broken into 4 categories. It's very egotistical on our part because, I'm a researcher in Ontario and we're reflecting that. And then we have Atlantic Canada, and then we have Quebec, and then just the rest of Canada, basically, the West. But this is mostly because of sample size issues. And what we see here might give us some insight into what we're seeing with the differences in Canada and the US, because Ontario and Quebec had very different approaches to the pandemic in the early phases, where Ontario took much more stringent lockdown measures, higher fines. There was a much more united effort, whereas in Quebec, they were a little bit slower to make provincial level determinations and legislative changes and bylaws. So we might be seeing some kind of a difference there in terms of how public health communication can impact people's psychological well-being, short-term and long-term. But that's more of a discussion for the public health experts and epidemiologists, not for somebody who's just doing workplace research like me. So hopefully we'll work with some of those folks to make sense of this data beyond just workplace. So getting close to wrapping up here in terms of what contributes to PTSD in these samples that we're looking at, all 3 samples. We see these commonalities of fear, workload. So from a workplace factor, the higher your workload, the more likely you were to experience symptoms of post-traumatic stress disorder. Lack of effective leadership, which we already talked about. Job insecurity. Psychological safety. So the extent to which people don't feel comfortable voicing their concerns at work, whether that's about PPE or whether that's about work from home policies or sick leave policies or just feeling comfortable in general, also a predictor of post-traumatic stress disorder. And some major kind of individual level findings, and we extrapolated some of this from a work from home study that we were doing as well, where when we're thinking about some kind of social determinants of health in our particular samples, and this is Canadian samples for the most part, we see differences between individuals as well. So it's depending on whether you have dependents at home, so what your family situation is, competing responsibilities related to elder care, homeschooling, or managing caregiving while also working. Personality, so people who are more extroverted tended to experience higher levels of strain and anxiety, as well as people who had a basically poor or ineffective work from home environment also to experience these higher reporting levels of poor health. So people who were high on the, or who had lower levels of lower quality work from home tended to experience more acute stress as well as more chronic stress. And looking at this too, though, in terms of the good news is that we know that there are lots of things that organizations can do to promote safety behavior and protect psychological health and well-being. And what we saw in terms of predicting safety behaviors are things like organizational policies that are family-friendly, that allow for flexible sick days, that already had sick leave policies to prevent people from coming to work when sick. So basically having paid sick days or personal days. Psychological safety, again, coming up as a really significant one, and transformational leadership. So people who had leaders who showed individualized consideration, inspired employees to behave safely, were innovative and flexible in this situation, and who led by example. So those people tended to be those who mental health was more consistent across time, and who tended to actually engage in safety behaviors. And it's kind of this balancing act between how afraid do we want people to be motivated, but how we don't want them to be so afraid that they're developing significant mental illness. So anyway, ultimately these results, when combined and taken with a bit of a grain of salt, because it is still we're still collecting this data, is demonstrate that we are modeling, what we're modeling here is in alignment with what we'd originally hypothesized, and that there's evidence that the pandemic is emerging as a traumatic stressor for a lot of people. And what we want to learn a little bit more about is whether this is a linear process or not. And we suspect it isn't. We suspect there are curvilinear processes going on here in terms of how PTSD may increase over time as a result of changes in resources. The implications are that their employees continue to experience stress and feel traumatized, even months after the declaration of the pandemic, and that organizations can play a really critical role in maintaining and enforcing public health standards through leadership, solid communication, psychological safety, and by providing reasonable workloads. So, and as part of that, ensuring as much financial security or job security as possible. And the bottom line is that although we're all in the same proverbial storm, we're in very different boats. And we see that comes through really strongly in terms of some of the individual factors that predict whether or not someone is likely to experience that cascade from a healthy level of fear to mental illness in the form of PTSD and other general health issues that we're observing. So the take-home message here is that this is a collective experience, but with very personal journeys. And organizations need to pay attention to that when developing policies and taking into consideration there really are individual differences that need to be attended to best support all employees. So thank you very much for your time and attention. Nicole, I'm happy to take questions.
Thank you, Jen. Thank you so much. Fantastic data. when you do start getting publishing these data, I think they're going to be very, very important. It's a wealth of information, and it looks like it's really because of the contributions of multiple investigators with different perspectives. So it was really great hearing about what I know. I knew a little bit about what you've been doing, but this is and sharing this information is just it's really great and really going to be important in, I believe, shaping our organizational knowledge about responses to pandemics. So I know there are several questions, so I'll turn it over to Nicole.
Dr. Dimoff, that was fantastic. And I was really struck by how it really correlates and I think really enhances the stories that we heard from Dr. Dagher earlier this morning. And so I do have a couple of questions related to that. People were really fascinated by study number 2. And I have a couple of questions there. Number one, what was the role of leadership in that study of retail workers? And I wonder if this is about proximity, or is this a higher touch relationship? Just kind of, can you describe a little bit the supports there?
Yeah, absolutely. Absolutely. So speaking from just a pure data perspective, it looks like, based on what we've collected and cleaned and everything, that supervisor support from your immediate kind of shop supervisor, so the person that you're seeing most often on a regular basis, had a greater impact for retail workers than, say, higher levels of management. So there's a difference between perceived organizational support and perceived supervisor support that was kind of unique to retail workers. And in terms of whether they were likely to feel that their workplace was protecting them. So basically holding all things equal in terms of policies, in terms of organizational, attendance, changes that were made as a result, or scheduling changes that were made, or even pay increases that were made at the organizational level, those mattered a lot less than how people were being treated at the front by their immediate supervisor.
Oh, that's fascinating. And boy, you set us up really well for the next question, which had to do with, in that same study, was any data collected on overtime or longer hours due to absenteeism?
Great question. So we did collect that data. We haven't looked at that data yet. We were looking at it in terms of, we aggregated some of it to basically form a workload construct or measure, I guess. And to my knowledge, it wasn't predictive of anything, but that's certainly something that we're trying to explore in terms of those more chronic stressors. So it may not come out as a traumatic stressor, but it may be the vehicle by which these objective experiences of working longer hours or working in more difficult circumstances behind plexiglass and with a mask on can have psychological impact on people that then translates in the increase or translates to more traumatic. So it's a really good question, and I think we have the data to explore it. So it's just a matter of getting to that point. So thank you.
So am I thinking on the right track here? And that is that, might it be that the supervisor's supportive behaviors may be a mitigating factor?
Yeah, that seems to be what's standing as clear for these retail workers. Without diving into it really nitty gritty, I can't give a great answer. But yes, I think if we're talking just generally, yeah, it makes a big difference.
That's brilliant. And then, the role of PPE, as PPE plays a role in actually physically protecting us, but it's also maybe a symbol of support.
Yes.
And do you have any insights into the role of PPE on employee fear and longer term outcomes?
Yes. So A lot of, in Canada, we were getting a lot of public health messaging early in the pandemic of don't wear masks because masks are going to increase face touching and that increases the spread of the virus. And so there we had a lot more mixed responses at time one in terms of whether people felt supported by organizations providing masks, for instance. And there was the whole political scenario surrounding that as well, in terms of that masks or medical grade masks should be saved only for healthcare workers. And so there were a lot of mixed kind of perceptions of whether providing the PPE was supportive or not earlier on in the pandemic. And we saw that in qualitative responses too, of people kind of saying, I don't really know how to feel about this. My employer is providing hand sanitizer and masks, but public health is telling us we shouldn't wear masks. And I don't know if I feel more or less supported. So there's a lot of ambiguity there. As time went on, people certainly were much more appreciative of organizations that were providing PPE and were reporting much higher levels of feeling physically safe and, interestingly, psychologically safe within their workplaces. I suspect we're going to see that kind of trend lessen over time, because now in most organizations, at least in Canada, the provincial and federal level, certain types of PPE are required. So it's not something that the organization is doing out of the goodness of their heart or out of doing to support employees. It's mandatory now. So I think we will see differences in that more recent data collection. Yeah.
Thank you so much. I just have one more that just came through. I'm just going to read it directly from the window. Any insights or data about increased unpaid caregiving responsibilities having an impact alongside paid workflow issues?
So, yeah, we have some data on this from a specific, so it was a work from home study that we did, and the gender differences are some of the most statistically significant in terms of putting them on a bar graph that we're used to seeing. And certainly with, more women experiencing comments even surrounding their commitment to their work, feeling, feeling of inadequacy in multiple areas of their lives. So I'm an inadequate worker and I have low self-efficacy is really how we measured it in terms of being a parent, and low self-efficacy in terms of being a worker. And so those are self-reported kind of experiences of performance in paid versus non-paid work. Our studies haven't really dealt in, a huge amount of information in terms of looking at caregiving responsibilities. We certainly see people with kids are having a much harder time balancing work and non-work, whatever that looks like. Kids or people who have to engage in homeschooling responsibilities have even more on their plates. So there are those more individual level. There are lots of researchers right now who are doing this work, family and work home research at a much higher level than we were. Wasn't our primary focus. So, and some of that research is getting published right now. I think there's a study published in both the Journal of Applied Psychology and then one possibly in the Journal of Occupational Health Psychology that specifically kind of focuses on exactly your question. So if you look at some of the more recent issues of those journals, you'll likely be able to find a much better answer than I can give you to that question.
Well, I just appreciate so much you pointing us in the right direction and kind of getting us on track. And this was brilliant. I'm so excited for the future of this study. Thank you so much.
Well, thank you, Nicole, and thank you.
I have one more question because I get as we talk about the experience of trauma due to COVID, I just keep thinking about the experience of trauma due to everything going on these past 8 months. So systemic racism, COVID, politics, all of that, really climate change specifically. And are you going to be able to tease apart that in your data? And you may not be able to, because it would take a lot of foreshadowing.
Yeah. But so this is kind of where we go back to February and March when we were designing this stuff. And for those of you who are researchers, this was a very unique situation where we were creating hypotheses and then starting the data collection within a week. Getting advanced IRB approvals, so it was very, so we made some good decisions, and part of that, and some bad ones, but part of the good decisions were collecting data about location. We collected some very preliminary data in terms of political ideologies, in terms of race and ethnicity. And so I think that through those variables, and they're not, I know that it's only 3, but with those 3, we're hoping to be able to look at those factors at the very least as moderating variables in some of these larger relationships. The big question from a statistical perspective is whether we'll have the power to do much that's particularly complex, because our biggest data set, which will be all Canadians, provided everything continues to go well, we will have 9 or 10 months of data spaced 3 months apart for about 2,500 people. And so that's our largest data collection. When our retail sample was only 500. So there's limited statistical power there to do more complex analyses, but there's certainly argument to be made in terms of, like, we're starting to look really closely at age as a factor. And we're hoping to work with some people who are public health researchers who can kind of provide us with the more macro level perspective on the impacts of the election, on, systemic racism, on all of the events that have been unfolding. And that's part over the last, a lot longer than a year, but certainly it's become very intense in the last 7 months or so. Anyway, and with the Canadian sample, comparing it to the United States sample, we might be able to get even more insight into that. So anyway, long-winded answer, but I hope so. Yeah.
Great. Thank you so much. Thank you very much.
Thank you.
For joining us. And that was excellent.